Everyone, good evening, and thank you for joining this um, our webinar series of Boost. I am Dr. Francis Roy. I'm an orthopedic surgeon and also the chairman of the SHO wing. And the SHO wing comes under the healthcare division of CAHO. And the outset, I thank and welcome our Father Johnson and Ranjit, who are born behind the healthcare division. And as we know that SHCO, small healthcare organizations, are a backbone for healthcare in India, almost taking care of 76% of our healthcare and nearly about 90% of bed strength. And we have unique problems that are pertaining to us. And this Boost series mainly looks into these issues, which are we are trying to get it to us, the common problems we as small healthcare organizations face each and every day. And the second series would be on is on on one of the important topics, which is insurance, and we have the experts on it. I welcome Dr. Babu, who's a director of Flab Healthcare and also a clinician and intensivist who has been with Flab for a long time and been working with SHOs, and Dr. Balamurugan, who is the chief operation COO of KIMS Healthcare Nagarkoil, who has also works in a rural setup where he has now established this new organization and taking it forward. I welcome you, sir. And I hand over it to the moderators, Bala and Babu, to take it over.
Good evening, everyone. So, as a doctor and as a healthcare professionals and as, say, managers, we have been delivering healthcare, which is a very important vertical in India. And as Dr. Francis Roy was saying, that 70 to 80% of the healthcare delivery is done by the small healthcare organization. With that background, where we are trying to provide a quality-based and evidence-based treatment to our patient, there is another important component into it. At the end of the day, whether the fair and justifiable tariff and the price, what we have put for delivering such a care is being recognized and it is being paid by the insurance companies. As hospital owners or otherwise as people working in the healthcare sector, we know that we have been facing a lot of difficulties in negotiating, in, say, talking with the insurance companies to get the full reimbursement of whatever have been spent on the patient for a very good outcome. But however, here we are finding it very difficult even to get the fair price what we have been spent for treating those patients. We are in a kind of a watershed wherein in future, the healthcare, what type of treatment has to be given to the patient, what has to be provided to the patient, what should not be done to the patient might be compelled or will be provided by the insurance companies. So here today we are at an important webinar which addresses to the core issues of the cashless treatment, which as I personally believe is one of the right of the hospitals which provides these healthcare services. Today's topic, to speak about the topic, envisioning a fully cashless experience, navigating insurance disputes with ease, we have amongst us Dr. A.K. Ravikumar, an excellent surgeon, diabetic foot care surgeon, and expert laparoscopic surgeon. Is a founder and director of Mouthi Multispeciality Clinic at Coimbatore. More than that, he had been a vigilant and a staunch supporter and an IMA practitioner for the past 3 or 4 decades. He had done a lot of work in that sphere, and knowingly or unknowingly, there are a lot of benefits we are reaping through his fight towards various aspects for the right of the healthcare organization. It is a privilege to welcome you, sir, for delivering this lecture on this insurance. The podium is yours, sir. Thank you.
Thank you. Thank you so much. Welcome you all, and very good afternoon to all, especially Dr. Roy. It's a good friend of mine who has been, we have been traveling together for nearly about 15 years, I think. Roy is known to me for more than 15 years. And Dr. Balamurugan, Dr. Babu, Mr. Adal, and Madam Gayatri. So we also have been in touch for nearly around the last 5 to 6 years. We have been meeting often in various forums. And I thank CAHO, especially the SHCO group, for inviting me for this very important firing problem, which all the hospitals, whether it is small, medium, or large hospitals, every one of us feel the heat of this insurance issue. So this heat can be just made simple, and it can be brought into cool if we follow certain things which the associations tell to our members. That is the most important one. You just imagine, it's only the 25 insurance companies controlling the nearly 40 to 50,000 hospitals who are empaneled with doing the insurance cases. So we are so powerful, but we don't understand that we are powerful. That is the basic thing which I just wanted to put forward before I share my slides on this. I may take a little more time than the 20 minutes which has been given to me. Please pardon with me if I am exceeding my time, because this, I thought, it's a very important one, and I just wanted to pass on the messages to all of you. Is the slide seen to all?
Yes, sir. Is
Yes,
it
yes.
visible?
Okay.
Yes.
Yeah, I will just go into the crux. So if you take the evolution of the healthcare to start with was mainly the trust among the service providers and the patient. That was the earlier days. We even don't bother to get asked for money, and patient, they will pour you with whatever they have in them. And that was the trust which we had in the earlier days. But as the healthcare gets evolved, and as the quality healthcare comes in, and as and where the gadgets have come out, the technical advances, scientific advances, everything has rocketed. Similarly, the cost also has rocketed. So you cannot buy an instrument without investing into that. And the patient's attitude towards the healthcare is also, they demand, they want quality at a mere cost. That is the, if it is affordable cost, acceptable, but it is for the mere cost they are expecting, not only the patients, but also the government, the insurance companies, everybody is like that. So now the money has become the primary one rather than the trust, and it has gone to the back seat, and money has become the primary one. So the doctor-patient relationship is lost, but we cannot afford to lose that, because the small family doctor concept, it has to persist, because India is a country with diversified systems. So we have various types of peoples, economic status of the peoples we have, and we have to take care of them. So it is the small, medium hospitals' role is very important. The doorstep healthcare delivery is very, very important. We cannot afford to lose that. So if you just go through the statistic, the healthcare provider, 70% is private, and only about 30% it is the government. And few statistics, if you just go through, India's doctor-patient ratio currently stands at 1:834, but this is not uniformly distributed across the country. In some of the states, for example, in Tamil Nadu, if you take, it is very, very less. We have achieved the WHO's norm of 1,000 population. We have crossed that, and we are somewhere around 634 per population, if you see that. So, estimated ratio of about 69 practicing doctors per 1,000 people is around 2030. The bed capacity in government hospitals is growing steadily, and it is now 4.7 lakhs. And as per the Tamil Nadu CEA statistics, 7,000 hospitals are less than 100 beds, whereas only 350 hospitals are there more than 100 beds. So you just see the small, medium hospitals are still the service providers. But why we want to go for health insurance? Is it really a mandate one that everyone should take a health insurance? Yes, because the hospitalization, let it be a poor person, let it be a rich person, hospitalization expenditure is definitely high. We cannot deny that. So 140% in the rural area, 90% in the urban area of their annual income is being spent on the hospitalization. That leads to poverty in some of the status, in some of the patients' family. In older days, the health insurance was in a type of interest-free donation. People used to come, relatives used to come to the hospital. They will be just giving you, they will be just keeping the money underneath the pillow of the patient and go. They will share the money to them. They will be just keeping the health-related expenditure. It's an unexpected expenditure. The relatives and friends will share the burden. But now, the situation is different. You cannot expect any of your relative or friends to come and give money at the time of the need for you. So things have changed now. So the health insurance is a must for each and every citizen of the country. We cannot deny that. So what is health insurance? Health insurance is financing for the medical expenses, which is an unexpected expenditure for any individual and a family. So this financing may be full or partial, depending upon the various schemes and the various policies which we take. The health insurance through healthcare through the insurance, if you just go through the statistics at present, the government is somewhere around 50 to 55%, and the social schemes are somewhere around 10%. Still, the non-insured and insured people are around 30%. They are untapped category. Mostly the middle-class people, they calculate each and every penny and they are not taking the insurance at all. And in the private insurance, they work only for about 9 to 10% as of now. So, which is steadily increasing at the rate of 20% every year. So, no doubt in the future, each and every individual who walks into the hospital will have either a government card or some social schemes card or a private insurance card. This 30% will come down to around 5 to 10%. So how it works, the insurance, how it works is, it is either the individual or the government or the various institutions, they contribute to the common pool, or from the taxes, government health taxes, they contribute to a common pool. This common pool amount is being managed by the insurance companies or the trust, in a trust model, in the trust of the governments. So that common pool of amount is being given to whoever is in need at the time of the disease. That is the expense. So benefits of the health insurance is out-of-pocket expenditure comes down. It is very important. Second one is the quality treatment is being given at the affordable cost. That is another very good one. And third most important one is the cashless service. So this cashless service is there. So this we will deal in depth today. And the government, our Indian government is the signatory of the WHO's flagship program of universal health coverage. So India is the signatory for that, and India is marching towards that. And there we feel the crux and the problems. But the thing is, the universal health coverage is for everyone, everywhere. That is, whether it is the poverty-stricken people or in the cosmopolitan city, everywhere. And essential health care should be given without any financial burden. That is the motto of the universal health coverage. So with this universal health coverage is being on the line, the unhealthy sign which we face in the country, in India, is, you see, nearly 200 smaller and medium hospitals have been closed in Andhra. Smaller hospitals have almost vanished in Kerala. Hospitals are for sale and lease. You can see these advertisements. If this persists, the access to the healthcare is questionable. So India will suffer. The purpose of universal health coverage will get doomed if the patient doesn't get the health care at the doorstep of his house at an affordable cost. It is very, very difficult. So at present, the health insurance, how it works is either the government or the policyholder, the patient, he pays to the insurance company, and the insurance company pays to the service provider. So that is we, the hospitals, and we give treatment to the patient. Actually speaking, this money or the policy money which has been given to the insurance company is going to manage it. It is between the policyholder and the insurance company. Why we should be brought in and why the insurance company should pay us. This is a very big question mark which all of us should think. If you have not thought about that, at least now you start thinking about that. So it is the money between the insurance company and the patient or the government. Why as service provider? We are the service providers. That's all. When a patient, whoever it may be, whether the insurance patient or non-insurance patient, if he comes to us, our job is to give the quality treatment to him and get our share of money, which is calculated. And we have to calculate. No longer you can just like that get the money. You have to calculate how much you are spending, and that calculation I will tell you as I go down. So it is between us and the patient to give the service. For this service, the insurance company has to pay to the patient and not to us. This is the principle for which we have to fight. But the existing system is totally different. Insurance company is controlling us and he gives peanuts to us, and we have to give the the high quality care to the patient. So that is the situation which we are all facing. Please think over that. I am just repeating that. Okay. So the insurance company pays less to us. We are unable to extend the required service to the patient. So for which let it be AHPI, let it be CAHO, let it be IMA. So all associations, we are all fighting for that, this payment by the insurance company to us, which is very, very less. For that only we are fighting. And the problems related to the insurance in current situation is empanelment issues. In the empanelment, there is selective empanelment. They don't empanel all the hospitals who wish to get empaneled. And there are various clauses in the empanelment about which my staff will be talking to you about. And payment issues. We have plenty of issues on this payment, and suddenly a hospital gets depaneled, and packages and discounts. These are the major crux which we face with the insurance companies. And now that they are pressurizing, and the IRDA and the insurance companies are marching towards 100% cashless, for which a committee was there, we fought with them, and we have kept in abeyance. Otherwise, it would have come in, that is 100% cashless, where there will not be any reimbursement portal, but we have stopped it, and I'll explain to that in detail. So the selective empanelment of the hospitals, which is very, very cannot be accepted, because it is the patient's right to choose the hospital and to right to get the treatment. And equally, all eligible hospitals' right is that we have to do insurance, and we have to get empaneled in the insurance with the insurance companies. That is our right. So there is no coverage for the pre-existing diseases as far as the patients are concerned. The low packages are non-sustainable for the service providers. When the packages are low, quality care is at stake. So failure of the government schemes for want of funds, they don't have enough funds. Their per capita expenditure is very, very low. GDP spend on health is very, very low. And settlement issues. So we have faced, all the hospitals would have faced settlement issues. They would have authorized one amount, they would have settled a certain amount to you, and whatever mail or communication you send to them, they will not respond to you at all. So these are all the problems which we face. And if we talk with the insurance companies, they say that the claim ratio is more. And that is why they are facing the problems. That is their issues. So there is a lack of awareness among all the stakeholders. So we ourselves, we don't have enough knowledge, unless only few of the office bearers who are playing with this and fighting with these insurance companies have certain knowledge about these things. Otherwise, none of the hospital owners, they have a perfect knowledge about all these things. So this selective empanelment and packages, if you see, the patient's right to choose his doctor and the hospital is violated. Golden hour is lost in emergency, and he has to run from pillar to post in search of the empaneled hospital. The quality healthcare is affected, and all eligible hospitals, we have the equal rights to get empaneled, and package rates, very, very horrible. And end-to-end, it is the end-to-end specialized rates for selective procedures. It is fixed mutually between the service provider and insurance company. I am just mentioning this. Actually, you have to sit with the insurance company, discuss with him, and you should claim that this is my rate and you should give this rate. But that is not happening. Insurance companies, they boss over, they give certain rate to you, and you people also sign for that peanuts. And once you sign for that peanuts, you are obliged to do that. And if you are not doing that, he will depanel you, he will penalize you. So that is the problem now. So government fixes for the government schemes, whatever fight we do with the government, they least bother, they fix their prices, they hand over the scheme to the insurance companies, and the insurance companies fix the rates for you, packages for you. And we also sign for those peanuts. That is there. We have to awake ourselves. Yet, if all of us take an oath that we are not going to sign for these peanuts, the insurance companies will bend down and come to us. But we are not doing that because we are not united. And quality healthcare involves cost. Nothing is without cost. You have to invest on it. Who is going to give? Is government giving any subsidy for your investment? Is government giving any subsidy for land purchase or any of the healthcare equipment purchase? Are they giving electricity under any special category for the hospitals? No. But they expect the packages should be low, and we have to accept those packages. So these package rates will curtail the freedom of the treatment. Your hands are tied. You cannot give treatment of your interest and your choice to the insured patient. So the healthcare inflation on the other side is mounting. India's healthcare medical inflation is around 14%. And if you just go through the causes for this medical inflation, nothing is in our hands. As a hospital owner or as a treating doctor, the infrastructure cost, is it in your hands? The technological advances and high equipment cost, is it in your hand? Can you control those rates? Rising diagnostic costs, is it in your hand? Rising drug costs, the drug control doesn't control. We say that it is the drug control. They don't control at all. Disparity of rates in the drugs. Manpower cost, you know, we fought with the associations, IMA, AHPI, all of us, we fought, and the minimum wages, it went on for nearly about 4 or 5 years, and we have achieved now to a certain rate. And professional fee, you become a doctor, you become a super specialist after nearly around 15 to 20 years of toiling. And then if you come and charge, doctor, நீங்க சர்வீஸ் பண்றவங்க இப்படி எல்லாம் சார்ஜ் பண்ணலாமா நீங்க? So should we go to the roads? And need for quality care and patient safety is the utmost one. We have to do that. It is our responsibility to see that every patient is safe and our healthcare delivery is in a good quality. But quality means cost. So compliance of statutory norms, there are more than 60 licenses, the license fees plus bribery. All the 60 licenses are not going to get by mere fee alone. You have to give speed money. That also comes in there. Increasing taxes. Now, nowhere in the healthcare you have a lesser tax or special tax for you. A lack of subsidies. And on the other side, Consumer Protection Act. So we all go for the defensive practice. Indirectly, we have to do certain investigations. Though you feel that this investigation is not needed, you will have to do that. And this indirectly increases the healthcare cost. So if we just go through this data, diagnostics, the medical inflation is 40%, medicines 50%, room charges based on the infrastructure cost, it's around 15%. So if you see, all these things are not under our control. Only thing which is under our control, that is the professional fees, that's why it is only 10%. Because we don't charge much. We think about the patient, we think about the pocket of the patient, and then we reduce our cost only. So that is the situation now. So the National Sample Survey, it's a 75th round, which was done in 2020, that itself shows that the government, the public hospitals, they spend in rural area for each and every hospitalized patient 4,290 rupees. A private hospital spends nearly around 27,347 rupees. It's in the rural area, and in the urban area 38,800 odd rupees for a mere simple hospitalization of a patient. But the insurance companies, they give you peanuts, and the government insurance, they give rather, even not that, they give kadugu, peanut kudilla, kadugu size, they are giving the amount, and they are pressurizing us to do that, do the job. Is it possible? So the 100% cashless, which the insurance companies and the government, which are trying to force on us, here not all eligible hospitals will be empaneled. Only the hospitals who accept the rates which they throw will be empaneled. And only hospitals accepting their package rates will be empaneled. Patients' right to select their doctor and hospitals will get curtailed. And there are umpty number of cases, Supreme Court cases, the court verdicts, which says that insurance firm cannot decide on medical expenses limit. And the state health scheme is not a charity. Government cannot reject that. They have to reimburse the amount whichever the employee has spent for the health care. So these are all various things which are available, but none has been implemented. And we also have not fought for that. And in that scenario, the status of the small, medium hospitals in India, the survival strategy itself is very difficult. But don't worry, doctors. The small, medium hospitals will survive. We have to survive. And there are strategies how we can do and how we can survive. So this is the costing methodology we did in 2018 itself. And we have been continuously thrusting into our members, the government, the insurance companies, and slowly we are penetrating in and we are achieving one by one. So the standards which we followed is the Clinical Establishment Act. The government, the Central CEA Act by itself has given certain standards. If you follow those standards itself, the cost comes enormous. The Indian Public Health Standards has given that these are the number of staffs you have to employ for a 50-bedded or a 100-bedded hospital. So they have given standards. And the IRDA has come out with a format how you can bill to a patient. So you can follow those standards. And the Minimum Wages Act says that this is the amount you have to pay for your staff and the professionals. So if you work on those standards itself, we have come out with a billing format. So the IRDA billing format, if you just go through, there are various 9 components in that. Are we billing like that? I'll just show you those components. You have to do accordingly. So now, if you go through the costing, there are 2 components in it. One is the fixed cost, which we can provide. And the other one is the variable cost will vary according to the patient and must be for the actuals. So hereafter, don't give any packages to any insurance companies. You divide it into fixed cost and the variable cost, and fixed packages for the diseases will curtail the quality care to the patients and also affect the sustainability of the hospitals. So hereafter, you give the fixed cost and the variable cost. We just go through the billing of the hospital. This is the IRDA billing format. There are 9 components. One is the room and nursing charges, ICU charges, OT charges, medicines and consumables, professionals, investigation charges, ambulance charges, and miscellaneous charges. And if you have any packages for certain things, you can put it there. So these are the, and each one has got a different component. Enormous components are there within that. I'll show you at the last what are the components there. And so the fixed component, I am just giving the gist about it. Accommodation cost. You can work out your hospital accommodation per day for your room charges. You can fix it out, and that is a fixed cost. And you can work out on the employees' cost, how much employees are there, how much you are paying them, and monthly. And you can work out, we have a template for that, and you can work out and you can say the employees' cost. That is a fixed cost. And administrative cost. You have various other licenses, you have various components in the administrative things, and those can be worked out and you can fix that cost. And equipment's cost. These are all fixed costs. Variable costs, the consumables you use for a particular patient. The same appendicitis the consumables will vary from patient to patient. You cannot say that I'll be using only this much of consumables for this particular procedure. The medicines, this may vary. Now that the quality, you do culture, the culture-based antibiotics, it comes as resistant. Higher antibiotics are only sensitive. So you may have to use higher medicines and implants. These are all not in our hands. For each and every patient of the same disease, it will change, it will vary. So it is a variable cost for which you should not accept for packages. And investigations, you may not know what all investigations you are going to do for that particular patient. If he comes with an acute abdomen, the investigations will change from patient to patient. If he is a cardiac patient, the investigations will increase. If he is a diabetic patient, the investigations will increase. If he goes in for sepsis, you have to increase various types of investigations. So nothing is in our hands. So it may change from patient to patient. So it is a variable cost. And professional fees. Again, the professional fees, a procedure can go for half an hour. A procedure can extend for 2 hours, 3 hours. Then the professional fees will change. A new entrant, he's a new entrant, his charges will be different. An experienced doctor for 30 years of experience, his charge will differ. So those things you cannot come into packages. They are all variable charges, which you have to put it. If you go to the micro components, the outpatient, you have to work out room rent, OT charges, ICU charges. For everything, you have to bring in the accommodation, employees, administrative equipments, all those things you have to work out and bring it into that. And visiting consultants, you have the specialist, you have the super specialist. So you fix up according to their specialty and their expertise and their experience. You have to fix the rates. You just like that, it cannot be generalized and give these charges. And minor, semi-major, and major, you can just work out on that, and it will definitely vary from patient to patient. So this is the template which we have developed from IMA and we have released. And if you just go through that, the yellow ones are the ones which are fixed components. The green ones are in the variable components. It's only an example. It's a small example which we have done it. And for a procedure, say for a cesarean section in a small 50-bedded hospital, it cannot go less than 1,15,000 rupees. It cannot go less than 1,15,000 rupees. This is the break even which you will be attaining if you charge like this. And these are all certain workouts for a 50-bedded hospital with the standards which the CEA and the IPHS has given. If you can see a single room, private non-AC, you have to charge minimum 5,000 rupees. And for ICU per day, it is only the accommodation and the bed charges and monitoring charges, that is 10,000 and odd. And for OT charges per hour, you have to charge. First hour this much, and every additional hour you have to charge. And O2 charges, you have to charge per hour. Whether it is in the ICU, you have to charge differently. If it is in the ICU with ventilator, it has to be charged differently. If it is in the ward with a mask, you have to charge differently. So these are all the various things which we have worked out, and it is available in circulation. And to pressure us, a case has been filed in the Supreme Court, and the PIL has been filed, and they are asking for standardization of the healthcare cost, which cannot be done, which cannot be practiced at all. So for which the IMA has implemented, the AHPI also has implemented into this case, and we are fighting that the standardization of the healthcare cost cannot be done, and hope we will succeed in that. We are fighting on that. And this is a model which I am just proposing for you people to think about. That is, this is a proposal which we have given to the Finance Department of Government of India. Insurance company, I told you beginning itself. So this is the patient's money. Insurance company has to deal with that, and he has to settle to the patient. As service providers, our job is only to do service to the patient. So insurance company or the government should not control the service providers. Our hands must be free to handle the patients. If this comes out, our right, the patient's right to choose the service provider will not get affected. Right to have his choice of treatment will not be affected. Payment does not restrict the treatment option, and the patient, whatever the as per his policy terms, if a rate has been fixed for that, he will get it from the insurance company. The rest he will pay from his pocket. That is called the co-pay. Or if it is equivalent to the amount, he will jolly well get the cashless through the insurance company directly to him. That is called the direct benefit transfer. That is called the direct benefit transfer. The government can also do that. The government is giving subsidies for so many other things. For example, the gas and electricity, they are giving so many subsidies. So they can link with the patient account. They can directly transfer to the patient. That is called the direct benefit transfer if the patient gets admitted and gets the treatment. This is the model which we have done it. And the hospital empanelment, IMA has been fighting it. All willing CEA registered hospitals must be registered and allowed to handle the healthcare insurance cases. All willing eligible hospitals must be registered with all insurance companies, and no selective registration should be there, which we have one. And now the General Insurance Council has agreed for a single window portal. A common empanelment is going to happen, and a pilot project is going on for only the eye hospitals. They are empaneling, but only crux there again is the packages, for which we are fighting. And we have given the model of fixed cost and the variable cost to the Insurance Council also to work on it, and hope we will win over that. And once it comes, any hospital can get empaneled with any of the insurance companies at a single stroke in a single portal. So that we have succeeded. We have been fighting for this since 2017. I was the member of the Insurance Redressal Health Insurance Forum of IRDA. This was presented to them then in 2016-17, and now only it is getting materialized, and we will succeed in that. And another one is the cashless. They came with 100% cashless, and they were about to implement. Last 2 years, we fought with them, and we changed that to cashless everywhere. So this cashless everywhere is here. The reimbursement portal will be there. Cashless portal also will be there, where the empaneled hospitals will be doing the cashless. You need not be empaneled to any of the insurance companies, but if a patient walks into your hospital with any insurance card, there again you can do cashless. That is called cashless everywhere. So there is a portal for it. You can go through that portal for the specific insurance card or insurance company who comes to you if you are not empaneled. And there is an one-time MOU which you have to sign it. For that one-time MOU, you need not go for the packages. The notification says that you need not go for packages, but the insurance company will insist you on signing for the package. But you boldly say that I will not sign for the packages. You pay for the actuals. You will agree for that because patient has come to you believing that Dr. Francis is going to treat him. And if Dr. Francis can say that I will not sign for the packages, you give me the actuals, he has to agree and he has to give that. This we have fought and we have got it. That is called cashless everywhere. So I request you all that please don't sign for packages. Don't worry that you have got empaneled with any of the insurance companies or not. Even without empanelment, you can do cashless to your patient, and you ask for the actuals and do not agree for any freebies and discounts. That is it. And representation has been given. That is, the cashless contract shall be with the insurance companies and the customer. Customer information sheet. The IRDA has given a notification that each and every policy holder should be given with a customer information sheet. And this customer information sheet should contain, as per my policy agreement, if I have 2 lakhs policy or 3 lakhs policy or 1 crore policy, according to my policy, what will be my room rent eligibility, what will be my amount package for a particular disease. Instead of fixing the packages to us, IRDA has given a notification that you should tell his eligible limit. This is the eligible limit for appendectomy for a 2 lakh policy holder. This is the eligible limit for 5 lakh policy holder or 10 lakh policy holder. So this eligible limit will be given in this customer information sheet. And with this sheet, patient can select the hospital wherever he wants to go. So cashless payment to the policyholder has to go directly. That is what we are asking for. Instead of forcing us to accept a package, we are asking for a direct benefit transfer. So this has been represented, and hopefully we will get that. And another one, a big breakthrough, is the grievance readdressal. This grievance readdressal, we have been fighting from 2014 when I conducted a national insurance conclave at New Delhi, the first national insurance conclave at New Delhi. We said that we don't have any platform as nursing home holders or the service providers to give our grievances. Policyholders, they have ombudsman. The insurance company, they have IRDA. Where do we go? You write to IRDA, they are least bothered. You write to GIC, they are least bothered. Insurance companies, they are least bothered. So 2014 itself, we asked for that. We wanted to form a forum, and slowly it materialized. And now they have come out with the grievance redressal forum. So the government, GIC is working on a robust redressal mechanism to start with. A single point of contact for each insurance company for grievance escalation will be put up in their website that they have agreed, and they are in the process. And redressal mechanism instituted in 3 states now, the Tamil Nadu, Maharashtra and Karnataka as a pilot project. And now to start with, they will be taking up all the cases where there is short payment or non-payment of the authorized amount. Now the problem which we face, many of the small, medium hospitals which we face is they give authorization for amount and the patient gets discharged. And when they settle the amount, they settle with short payment or very low payment. So this is a very big problem which each and every hospital faces. And to start with, they are going to take up all those things. If there is any short payment of more than 20,000, you can directly escalate to the General Insurance Council portal, and they will take up this issue and they will solve the issue. So that is the grievance redressal mechanism which has started rolling up. It's a very big achievement for all the fight which all the associations which we have doing it for years together. And this is the insurance grievance data collection form which is being under circulation with all of you. You can just fill it up, all these things. Other than any issue with the insurance company, you just fill this Google form. We are collecting the data and we are going to represent to the IRDA and General Insurance Council that the various problems with the which the service providers are facing, and we will try to get them solved. That is being done. Friends, we are also human beings. We also have to relax. You just can't work under pressure. You cannot sit on a firing pan and burn your bottom. We have to relax ourselves. Only unity can give us relaxation. My message is, please be united. What all the guidance your association gives to you, please follow that judiciously. You fill up the form of the grievance on health insurance. We will take it up with the insurance companies. Get ready and be united if the association calls for stopping the cashless. If we call for that, all of you should unite with us. And if we can do that, all the insurance companies will bow down to you. Thank you so much. Thanks for this opportunity.
Thank you very much, sir. It had been an eye-opener for most of us, and I think all the participants would have benefited from the extensive lecture what you have taken in the past hour or so, the walkthrough over the insurance, their rights especially. And here consolidating SAR's message that if we stand united, because we are the people who are going to provide healthcare services with utmost diligence and also a quality healthcare. And if we stand united, I think that we can be able to serve our clientele better. With this, we will move on to a next session. Over to Dr. Balamurugan.
Good evening, sir. It's a privilege to invite Ms. R.V. Shanthi, insurance manager from Moti Nursing Home, from Coimbatore. She is of more than 14 years experience in health insurance and claim process. and she is working in Infosys, and currently she is working in insurance manager in Coimbatore. So over to you, ma'am, on topic hospital empanelment process.
Hello. Sir, good evening, sir.
Good evening.
Services to the policyholder or beneficiaries. The empanelment process for hospitals with third-party administrators. So, few steps. Application submission, first of all. Second, document submission. Third one, verification and the inspection. Fourth of review and approval. And final empanelment. First of all, application submission. Apply through online portal by submitting a physical application to the insurance company. Next, document submission, registration certificates and legal license. So legal license means hospital registration certificate, fire safety certificate, pollution control board certificate, next CAHO certificate, accreditation certificates like NABH or NABIL. Next, manpower details and financial documents. Next, verification and inspection. So that process verify the submitted documents. Conduct a physical inspection of the hospital facilities, infrastructures, equipments, and staffing details. Next, review and approval. Submit a report to the insurance companies. Next, empanelment. If approved, the hospital is added to the network. Details are published on the relevant portal or platform. Now, handling difficult in empanelment process. So, lengthy documentation requirements, lack of clarity on policies or empanelment criteria, slow responses time from TPS insurance companies, low package rates or unfavorable terms. Next, delayed payments or claim settlement. So, precautions, prepare strong documentation before MOU with empanelment in insurance company. So, legal license. Next, accreditation, NABH certificate, financial bank details, GST registration. Next, staff, doctor's qualification certificate list, staff details, qualification certificates, infrastructures, equipments list. Next, rate cards, surgery packages, forms on the TPA forms. Handle and negotiate better package rates. Calculate your actual costing including OT cost, next implants and post of care and etc. So include overheads like salaries, maintenance, consumables and depreciation. So compare your rates with those offered by the TPS. If the proposed rates are too low, justify your costs based on quality of care, next unique or specialized services, next accreditation, examples NABH certificate. So next, if issues persist, so make sure you have dedicated insurance desk or team to handle TPA interactions. So consult with your insurance team who specialize in empanelment. Join hospital associations or forum to share experiences and get advices. Thank you, sir.
Thank you, ma'am, for the nice presentation. Dr. Babu sir, shall we move on to the question and answer?
Sure. So, Dr. Ravikumar, what do you think is the commonest reason, or maybe the top 3 reasons why we find difficulty? Because as a practitioner and whenever we are trying to treat the patient, I mean, as a physician, even when they admit with a high fever, when we have even a culture positive results and other things, even then there are insurance companies asking queries and queries and queries again and again. And most of them, they are trying to dodge the claim process. So what type of, maybe according to you, the top 3 reasons why do you find it difficulty, sir?
So the common reason which we come across is the insurance, the policy holders, mainly the policy holders, maybe a fresh policy holder. It's a first year policy. Many a times, the insurance companies, they don't encourage first 2 years of policy holders. Their tactics is somehow they wanted to just shrug away those insurance policy holders. So for such things, they will repeatedly ask questions and they will say that, as you said in the fever cases, this could have been treated as an outpatient. You need not have admitted. All those things they will put up. So that is one of the reasons. And second one common reason which we see as the rejection is non-disclosure of the pre-existing disease. This patient would have admitted for, say, acute abdomen, whereas he would not have disclosed that he has got hypertension for the last many years. And when you send the pre-authorization form, you would have mentioned that he is known hypertensive for the past 10 years. And this fellow would not have disclosed this. This is mainly because of the agent who says that இதெல்லாம் நீங்க கையெழுத்து போடுங்க நான் உங்களுக்கு பார்த்துக்கிறேன். So this pavam person doesn't know that he should have told this. And everything there, it would have entered that there is no pre-existing disease. Just because he has not disclosed the pre-existing disease, he will not get the claim here. So he will ask all questions and finally he will say that he has not disclosed the hypertension, but he would have admitted for acute abdomen. That has got no relevance at all. But even then, just because he has not disclosed, finished. That will be closed. So that is another one. The second reason, most common reason. Third reason is, just to openly say, the person who handles the file in the insurance side, if he gets some cuts for rejecting. So for example, 10 cases he is seeing today. If he has approved only for 3 cases, he gets cuts that 7 cases he has disqualified. So he gets some remuneration for that. So for that, incentives or something. So for that also, that is commonly being done. So if you just go through actual reason may not be there.
Yeah.
Our insurance desk people, they are very much experienced. They have worked for nearly about 10-15 years. Say they know. So whatever trick you play, definitely they will ask some queries and try to close this. So these are the common reasons which we come across and why they do that. That is
very relevant to my practice as well, sir. I mean, like in the quality and NABH, other things. And as a practicing physician, most of the time we wanted to be very thorough in collecting all the details, right from his from birth, all these things we try to collect it, and we, as a physician, try to connect it and come to some kind of a diagnosis and some value to it. But at the end of the day, that will be the reason for him getting rejected as well. So most of the time we feel guilty that we shouldn't be that much thorough. So that makes a relevance. And second, what you made is very yes, sir. Second point, what you made is very important, that whether it is directly linked to it. For example, acute abdomen getting affected, if he haven't disclosed that he's a known alcoholic and he has come for an acute appendicitis, okay, that is some kind of relevance to it. But an acute abdomen getting admitted for an appendicitis, whether the hypertension has been disclosed or not, it doesn't have any kind of relevance. So there the logic of irrelevancy is not put into effect, or otherwise the very intent of making for him to pay the premium to get his treatment is not being done. I think that is an important thread what you have touched upon, whether the particular disease is directly related to it, whether the disclosure is relevant or not. I think that's a very legal point as well, I think.
One another point is, now there is a use of, there is always another question on alcohol, or was he intoxicated on drugs or alcohol? This is another thing that they commonly ask. And by mistake, sometimes our doctors write under the influence of alcohol or smoker for so many years. That is also a very important point to note in the case sheet. The other thing is, at present, for all medical legal cases, any accidents, you have the company can ask for a alcohol test. It is legally now, you cannot write, just give a letter saying that no, he was not under the influence of alcohol. Now it is compulsory that every test, every person who comes for an road traffic accident has to have an alcohol blood test. But it's not available in so many small places. That's also another problem.
Gayatri ma'am, I mean, with respect to OG, do you have any special, I mean, like difficulties as a hospital owner? What is your pain point?
First of all, thank you, Dr. Babu, and thank you, Dr. Ravikumar, for bringing in a wonderful lecture on this, especially when it came to package rate that you have arrived with a beautiful costing, which clearly indicated that for a C-section, you cannot but break even unless you have 1.2 lakhs. You cannot break even. So our profit margins should actually start only after billing 1.2 lakhs. I want to know whether it is with or without the medicine bill. So that is one thing, that whether medicine bill is also a variable factor, whether that's been taken into account in the costing. And disposables, from general packs to everything, now every hospital, they are expected to be so clear in their aseptic precautions. Therefore, every patient wants general packs to be used in the hospital theater. So what is your take on, when you come to costing, how do you think this is going to justify?
Doctor, thank you. Thank you so much. That is only an example which I have given. Actually, I was telling that there are two components, the fixed component and variable component. The medicines, all those things, consumables, everything comes under variable component. So you can give only the fixed component. So that is an example that if everything goes on smoothly without any complications, and if you are going to use the standard medicines for a clean case, so that works out to that. If a small complication occurs, that will shoot up. So it is only a basic cost without profit. The rates which we have taken for the medicines to work out that is, it is only the landing cost, not even the MRP cost. It is only the landing cost which we have taken for calculation. Okay. So it is only a very, very meager minimum basic which we have used to work out. Even that comes to this much. If you are going to work out the actual ones, it will definitely go up. That's why we said the fixed cost and the variable cost. So medicines, consumables, everything is going to be a variable one. So hereafter, we have to submit to the insurance companies that my fixed cost is this and my variable cost will be this. That's it.
Thank you, doctor. Thank you so much. And one more small question I'd like to ask, what's your take on common facilitators like G-Money, people who want to do generally all insurances facilitated for a patient as a third party? So many small hospitals who are unable to have the manpower to deal with situations with the various insurance packages, is it good for them to go for such a common party?
No, madam. No, madam. That is not correct at all. There are so many cases on those people and they are easily escaping out. And the hospitals are into problem. So never go through a third party. So association doesn't approve that, because these fellows, they will lure you that they will empanel you with all the hospitals. One, I mean all the insurance companies. Second one is they will say that they will give a flow of patients to you. There is a case registered in Karnataka that one of these third-party people who promoted a patient to a hospital, the patient ended up in problem. This fellow went out saying that I have only shown the hospital. this is the duty of the doctor and the hospital, and we don't have any say in this, and he is out of the case now. So never believe such people, never go through that. You can go to the portal, you can empanel it, wait for some more time. Our fight is going on. Definitely the common empanelment is going to come. We are not going to leave it, and we will get it. And once that comes in the single portal, you can get empaneled to all the insurance companies.
Thank you,
That's
Doctor.
it.
Reassuring.
May I ask a question, sir? Thanks for the wonderful talk. I think it's been a big revelation to many. You touched upon the grievance redressal. I understand that it's recently come out, and I think thanks to your efforts, you brought it. But I just want to understand, for the benefit of all the audience, how can a hospital, I understand that it needs to be a registration. A hospital has to register under the grievance redressal
Yes,
platform.
yes.
So could you just throw light on that?
Yeah. So there is a portal through which you have to. So now what they have designed as of now is they have representatives from our side, and the council also is there. Council members also are there, and they have created a portal, and your this grievance you have to upload into that portal with all the details. So once you upload into that portal, this team will go through, analyze that, and if it is valid, they will ask the insurance company to pay back. So before that, you have to write to the insurance companies, apprise that such issue has arisen to you, and you should have communicated with the insurance companies. And if you don't get any result from them, then you have to come to this portal. So that is it. I'll share that to you. You can share to all your members. We have the mail that I'll send it across to you all.
Any time limit for that reply, sir? For example, say after writing to the insurance company.
Yes, sir. They have given 190 days or something.
Okay.
Yeah. Time limit is also there.
Sure. Dr. Balamurugan, from as a representative of a corporate setup, and now you're operating in maybe a tier 2 or tier 3 kind of things. What is the main pain point for you with concern to insurance?
The main point is that discount of different insurance companies. One insurance company is asking 5%. Now they're asking commoners, they're asking 10% on packages. It includes medicine, consumables, and all the fixed costs. So giving 10%, I don't think can survive.
No,
so how to deal with this, sir? Mainly the discounts.
Sir, yeah, here only I said no discount. My slide itself has shown that no discount. Don't go for any luring things. So no discount, sir. You just put it as 0% discount. If all of us follow this, they have to agree it. So that's why I said be united. You just put it as 0% discount. 0% discount. And another one, sir, at this moment, I just wanted to tell you all, we have a consent form. Whenever a patient enters into the hospital, we get that consent form signed. In that consent form, what we have written is, I have policy, and I am using this policy for this particular disease. And if the insurance company is going to give less than the raised bill by the hospital, I will be paying the balance amount, whether it is package or whatever it may be. I am going to pay the balance amount to you. So these three mandatory things are there. We get it signed from them. Point one. Point number two is, what we do is we collect. It is not an advance amount that we collect. What we do is we ask them to pay the visiting consultant's charges. That we just ask them to pay and get it and pay to them. And we ask them to get the medicines from the medical shop, stating that he has got not any link with the hospital per se. Medical shop is a separate unit. So they go and buy these medicines. So a considerable amount the patient pays for. And we have track record. We will show them to convince them that we are reimbursing the amount to the patient once the amount is settled to us. And during the settlement also, we showed to them that this is the approved amount, but you see how much these fellows have settled to us. This is between you and the insurance company and not between we and the insurance company. We have given the treatment. He has settled only this much of the approved amount. So this amount you have to pay. Because of your policy conditions, he has denied all these things. So we will give a receipt to you. You can go and claim from the insurance company. So all these things we have done it, and we smoothly it is going on for the last nearly about 4 or 5 years, I think. We have followed this. And this saves you.
Understood.
Babu,
Yes, sir.
one thing very important is that the counseling before by the team. If you see, generally in a small healthcare setup, there will be only a one-person insurance section. It will be not like a corporate where there are many people who are taking care of it. And it's very important for them to counsel the patient. What sir said, all the points have to be driven into the patient and told to them, see, your insurance policy is this, and the insurance policy is the second thing. The doctors of small healthcare organizations really don't look into the packages. Some package comes and he says tomorrow is the deadline or 2 days is the deadline. They just sign every page and give. It is not necessary for us to sign for the packages. You can give your own packages. What is viable for you? And as sir said, we are not legally bound to any of the insurance companies to give any discounts. And we have to stand by that. And another important thing is where patients come to us and fight for us, the consumables which are not included, which are excluded in the bills. And there are a lot of items that are excluded, like bed sheet change or disposables, disposable gloves and everything. And we have to, when we counsel the patient, it is the responsibility of the person or the counseling team to tell them that, see, there will be a copay for all of the disposables and some of the drugs which have been excluded from your insurance. We have to do this beforehand.
Sir.
Yeah, good point.
Dr. Nirmal sir is here. Sir,
Welcome,
your thoughts
sir.
on it, sir?
Welcome,
Sir,
Nirmal,
welcome, sir.
Good evening, sir. Thank you, Babu, and wonderful talk as usual, like here, sir. So
Thank
happy
you, sir.
to
Thank you.
have you for this discussion. Just wanted to add a few things what you highlighted. The non-medical expenses all along, if you see the last 5 to 6 years, they've been consistently excluding or including the so-called non-medical expenses into the package, saying not payable or not reimbursable. So we need to define that what is payable, what is included in the package, and what is excluded in the package. And as Ravikumar sir said, probably this is a important thing for small hospital to make the patient buy that in the pharmacy or elsewhere so that they can claim that as reimbursement. That actually reduces some of our pressure with this package system. And so whatever excluded, we can ask the patient beforehand to buy. The second thing is the counseling, and more important is documentation of the counseling. Very often hospital get caught in this, and the patient or attender keeps saying that it was not told to us, because there are 3 or 4 attenders who come with the patient in rotation. So we get our staff also get caught in this. So always document the discussion that has happened between the patient and the attenders, as well as about the payment issue. What is payable, what is not payable, and what is the copay amount, and a clear instruction to be got from the insurance company about the deductibles also. So we now ask for full and final approval before really admitting the patient for any surgery.
That's great.
That's wonderful, sir. Actually, rather than a kind of a webinar, it's a very good interactive sessions, and with the start words with so-called experienced people here and who had been very prominent in the healthcare domain, IMA, AHPI. I think a kind of snowball effect which is happening. I think under Dr. Roy's leadership, I think we have to come together. And as Dr. Ravikumar was telling, that it is a fight of every doctor for the sake of his patient, for providing him a good and a quality health care. I think all the minutes of the meetings and all the inputs what have been given by these experts has to be consolidated, and it can be shared for the benefit of those people who have registered and who haven't got the chance to attend to this very say eye-opener kind of a webinar. I think Dr. Francis Roy sir will look into it, and thank you very much, sir. And Dr. Roy sir, for your closing remarks.
Sir, lastly, sir, just I think I have shared the screen. Are you able to see that?
Yes, sir.
Yes, sir. Yes, sir.
Just to go through, see what are the components which the IRDA by itself has given for billing. If you say the room rent, room and nursing charges includes, you can see there, the section level code 1, general ward charges, semi-suite charges, hot water charges, bedsheet charges. So all these things you can charge. You can see nursing fees, dressing, nebulization, injection, AYA charges are also there. Blood transfusion, duty doctor fees, everything. If you go to the ICU, again, you have different components in that. So for which you can charge. So similarly for OT, if you just go through infusion pump, everything is there. So you can charge for each and everything, sir. That's why I said our template takes care of all these things. Major OT, minor OT, if you go labor, endoscopy charges, equipment charges, you can just go through this. So I'll just share this also to your team. You can just send it across to your people.
Yes, sir. Please share the relevant documents, sir. So
yes,
it will be very helpful.
Yes,
very helpful, sir. Dr. Francis Roy, sir, your closing remarks, sir.
What are thanks by Gayatri ma'am, sir.
Gayatri ma'am.
Yeah, okay. Thank you. Thank you, Dr. Babu. And first of all, I should thank our lovely audience. More than 100 people, they have been in the session for more than an hour and they are still waiting here for the closure. So thank you for this very prompt audience, first of all, and for the engaging discussion. Thank you, Dr. Ravikumar, and thank you, Ms. Shanthi, for sharing your views. And Dr. Ravikumar, that skeletal framework is so useful. It made us understand what this entire, how the structure works, and your costing will be absolutely very useful for the small hospitals. And the more important point that you have stressed is the unity part of it. We have to be united in standing together and not signing packages, not signing discount deals and at any cost. And if we stand together as small hospitals, we are the 80% treating the country. Therefore, we must be able to get through. Thank you for giving us this strength and unity. And thank you, Ms. Shanthi, for this explanation of the process again. And that was very useful and nice of you to join us. Thank you, Dr. Babu and Dr. Bala, for the moderation of the entire discussion. It was so engaging and so nice to see the discussion take shape. Thank you, Dr. Roy, for being there as the leader and spearheading this entire series, knowledge series that we are going to do for the entire state. And I would like to thank Father Johnson also from the Healthcare Division as the head for being there with us and taking care of every series, being part of it and giving us the go-ahead. And I think it's been a wonderful session today. As part of CAHO, I think I've been since year 2014. I think from that time till now, we have seen the growth of CAHO. And the most important thing I tell all the small hospitals that are here today is to join CAHO and take the packages that are there for training. Come and see what are all the various training modules that are available to train staff, to train doctors, as well as within the institution, making them understand what the processes are all about, and it will be very useful. And I think it's an eye opener for small hospitals for us to come together mainly. Thank you so much for this lovely evening. And if I have left out any names, it is not intentional. And thank you so much for being here today. And over to you, Dr. Roy, sir.
Thank you, ma'am, and thank you, sir, and both the moderators. There was one question in the chat box, if you have time, that is about reimbursement. Reimbursement, I think two things we have to understand. It is time bound. Most of the time what happens is we give a reimbursement bill late and the patient will not be able to. It is only about 5 to 15 days. Within 5 to 7 days, we'll have to give the reimbursement bill. If we delay it, then the patient won't get the benefit. So it will come on us. So please remember that. And thank you, everyone. Thank you for the wonderful session, and hoping to meet you all again in future Boost 3.0 and the next session to come. It's conducted on every last Saturday of the month between 4 and 5 p.m. So we welcome you to tell your friends, and also we would love to have the small health organizations as members of CAHO. We are trying to reduce our regular annual membership fees, especially for you. I think we need more representation from you all from all over India. Thank you.